Hi there. Do you know what time it is? It can only be one time because you are on with Fink and Friends. Good afternoon or good evening, CNY Nation. I'm Dr. Randy Fink, live from Colorado Springs, where it is 4 o'clock in the Mountain Time, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast. Fertility with Fink and Friends is what we do every evening, every Tuesday evening at this time. And so it is sure nice to see everybody. Hi, Grace. Hi, Ceciliana, Melissa, Nancy Gomez, Nancy Bernard from Miami. Hi, nice to see you, Nancy. And over here on the CNY side, our first joining us, Bland Wellness and Nick and Cram, it looks like. I hope I'm saying it right. Haley's Mama. We've got Chat with B and Wilkinson 27. We've got Kira Gallup. Boy, we've got, and look, my own mother in Southern Alabama has joined, and I would certainly like to throw a shout out to everybody in Mobile, Alabama, who is nearby my beautiful mother and father, who just recently celebrated, is it 66 or 67 years of anniversary, which is incredibly special, and what a gift they have given us all by still being with us and still showing us all what love is supposed to be. So thank you, and hi over here on the Facebook side to Tiffany. Hi from Atlanta. We've got Haley joining us here. Hi, Haley. Good to see you. Amber is with us here from Kentucky, and so we've got a bunch of different things going on. We have, as always, two different Instagram feeds, mine and CNY's. We've got Facebook and we've got LinkedIn here in the middle. And I want to give a special plug, in addition to that, shout out to my beautiful mom and dad. A special note about something happening this evening, actually at 5:30 in Mountain Time or 7:30 on the East Coast. And that is a talk. It's a Teams meeting, a special presentation that I'm giving on behalf of CNY Fertility, talking about reciprocal IVF. And reciprocal IVF is where we take an egg from one female partner. We use donor sperm, create embryos, and place that embryo back into the other female partner. So in a female couple, we have egg from one and the other is the carrier, and it's really a beautiful way to create a family. And so our special this evening in honor of Pride Month is about reciprocal IVF. My partner Brandis gave a wonderful presentation last week about some of the different options that we're able to offer for LGBTQ plus couples who would like to expand their families. And it's something that we really enjoy. It's something that I think is incredibly special to be able to do. It's one of the things that I enjoy most about being here at CNY. So please join if you would like, if that interests you, if it appeals to you, then on the Instagram, on the bio portion of the CNY Instagram page, there is a link as to how you can register for that program, which will start about 30 minutes after we complete our program tonight. So welcome to everybody. It's been a very, very rainy week here in Colorado Springs. In fact, just a little bit ago, we had some hail. The hail was actually pretty big. We've had some giant hailstorms in this area in the past, and it's just really interesting to see in June ice coming down from the clouds. But sometimes it's not so cool because it breaks windows and damages roofs and damages cars and that kind of thing. So, so we got a bunch of different things I'd like to talk about tonight. We'll certainly get to your questions in a few minutes. But as always, just kind of like to start out with some interesting and thought-provoking things here to talk about. Also met some really wonderful people in Colorado this week and had a chance to share some different stories, and it's always amazes me what brings people to us, and what, all the different stories, all the different experiences that they've had in their lives that bring them to the moment when they cross paths with me. Just today, I think we did 12 embryo transfers, which is where we're taking an embryo and placing it back inside the uterus in hopes that it will stick and result in a pregnancy. But how incredibly special it is for me to sit there and have and have that moment. And I always encourage people to try to record that, because we have a monitor here in Colorado. We have a monitor on the ceiling that you look at. And you see a little flash when that embryo goes inside the uterus. And I really think it's very special to be able to record that moment, because it's not often that you can see the very moment that you became pregnant. I suppose that can happen at home, but it's probably not something that you will show to your neighbors. Or if you do, it'll be quite an interesting party that you're having at your place. But the things that bring people to us, and all those experiences and everything that's happened in their lives in order to bring them to cross paths with me is just really a fascinating series of stories. And one of the things that's kind of been a theme with folks that I've been talking to this week about, what's on their mind and what's in their hearts, is the issue of guilt. The issue of guilt. And I'm Jewish, and so I'm a specialist at guilt. 5,000 years of Jewish guilt has certainly taken its toll on my psyche. But I think in this time when we are also we have technology at our fingertips. Social media is a common and regular part of our lives. That the acuity of everything going on around us in our environment, a 24-hour news cycle. You can turn on the TV at any particular moment of the day and hear every last thing that's happening in the news. It just makes us very kind of hyper aware, and sometimes even hyper vigilant. What do I mean by hyper vigilant? Hyper vigilant, or hyper aroused, as the case may be, is a condition that happens in the brain. And it is associated with anxiety. We all have anxiety, and anxiety is a very primitive. It's a very, very old reflex in our brain, going back to very early in our revolutionary time, when fight or flight. It's what we needed to do. Anxiety or fear about what's going to happen in our future. We needed that in order to stay safe from the saber-toothed tiger that may be jumping out from the tree line, or from the pterodactyl that's going to swoop down and try to steal our baby, or from the rival tribe that may come in and try to club us and take our food. A very primitive reflex. And that's what anxiety is. But hyperarousal happens when the portion of the brain, which is called the amygdala, when the amygdala is on overdrive. What is our brain doing? What does it need to do? Well, it's here to think, right? Suffering is such a big part of our lives, and anxiety invokes such a tremendous amount of suffering in people. And whether that's anxiety over what's going to happen as we get prepared for an embryo transfer, what's going to happen when we're retrieving our eggs, what's going to happen when we just go for our ultrasound or have a blood test done, what's going to happen with our family, what's going to happen with our friends and our extended family as our lives meander on down this path. When the amygdala becomes hyper aroused, what it's doing is that it's trying to justify our own existence, justify its own existence in the brain. It's trying to warn us about possibilities of danger. But what we have to know is that when we are dealing with anxiety, that probably greater than 99% of the catastrophizing that our brains want to do is unnecessary, that it's not realistic. It's nothing that's actually really even going to happen. That it's something that our brain is imagining because it's trying to keep us on our toes. It's trying to keep us on edge. It's trying to keep us what it perceives as safe. And safe does not necessarily mean comfortable, because as we all know, anxiety is not comfortable. And guilt is one of those things where we start to perseverate or ruminate on things that happened to us in our past and worry that in some magical way, those things are affecting who we are and really what we bring to the table right now. So certainly every experience that we've ever had affects who we are and who we become, how we interact with each other. And that's just the nature of life. But one mistake that maybe you made a long time ago, or maybe even not a long time ago, is not something that needs to define who you are. And it reminds me of a story that one of my patients this week told me. And she said that she told me that it was okay to share some of the facts here. She's a very successful finance person deals with banking and other people's money and that sort of thing, which is a very important job. It's something I certainly don't have the mind for it. So my hat goes off to her for being able to deal with that and to be able to stay focused on it. She found herself utterly racked with guilt over the fact that, and this sounds kind of funny, but over the fact that when she was in high school, she admits that she cheated on a test, that she didn't really intend to, but she looked over and looked at her neighbor's test and saw what somebody was writing down and realized that what she was putting on her answer sheet was incorrect, and she got her answer from the other person. And this act really came to define her on the inside over the course of many years, because as she grew more and more successful in her work, she became overly worried, overly concerned that she was a fake, that she should have never been there, because that one day back in, I think it was 11th grade, she copied off someone else's test. Was copying off someone else's test the right choice to make? Was it the right decision? Well, there's lots of moral answers to that. She certainly didn't do it on purpose. She just kind of looked over and there it was. But she changed her answer as a result. And she felt incredibly guilty about that. Well, over time, this guilt became, really consuming to her, this feeling that she was a fake, that she shouldn't be who she is. She shouldn't be successful now. And maybe this is sort of similar to if you still have those dreams about being in high school and that and that it's, the final exam and you never studied or you never showed up for class and now that it's over and you're not going to graduate, those kinds of anxiety dreams. I still have them. I absolutely do. Eventually what happened is that this young lady decided she would tell her boss. She felt like she had no other choice, but she had to come clean. She had to get it off of her chest because she felt like she didn't deserve the success that she had, owed to the fact that she cheated on a test. Well, what was the boss's response? The boss's response was, "You were in 11th grade at the time." And the metaphor there is you were in whatever situation you were in when you made your mistake. We are human and we make mistakes. We do things that we don't intend to. We hurt people that we don't intend to hurt. We hurt people who we love. We step on people's toes. We do what we have to do to get ourselves ahead in life, and sometimes at the expense of other people. Does that make us bad? No, it really doesn't. And that's what her boss went to impress upon her, that you're human and you've been very successful in doing things for other people, helping other people, and getting to the point where you are in your life. And the one mistake that you made some time ago in the past is something that you can let go of, because who we are is who we are now. It's who we are today. It's not who we were yesterday. It's what we bring to the table. It's how we can interact and help with other people now. And when she came to that realization, it's actually what made her realize that she wanted to add to her family, because she realized the beauty of the world is we never really know what's going to happen tomorrow, and that whatever the mistakes we made yesterday, they make a part of who we are today, but who we are now means something completely different than who we were before. And what we have to live for is who we are in this moment. So there's my interesting story of the week, and hopefully that means something to you. And as I've been talking here, I've been seeing so many nice people joining me on both the Instagram side and the Facebook side. And looks like I've got Nikki here from Texas, Isa Hernandez. Hello, nice to see you. Carly Tercios. Hey, Carly, good to see you. Jack 24, Iandre. Hey, is a duostem or a luteal phase egg retrieval best for diminished ovarian reserve or people who have a low AMH? That's a great question. A duostem is where you do IVF, and usually about 4 days after your retrieval, we start you on another stimulation. As opposed, and that is a luteal phase stimulation. As opposed to giving it about 10 days or so until you get a period, and then starting on another stimulation at that point. And that's what's called a back-to-back cycle or a stacked cycle. In my opinion, with the duostem, we sometimes get fewer eggs. A luteal phase stim can result in fewer eggs than doing a back-to-back cycle. And so the duostem was originally intended for women, for example, who had a hard stop on needing to finish IVF, let's say, before they were starting chemotherapy. Women with cancer who had to undergo treatment, but knew that they were going to be starting their treatment, let's say, on the 15th of the month. And so they had to get everything done before then. In that situation, we start your stimulation wherever you are in your cycle. You finish it 4 days later, you do a duostem, you start on another one. In my opinion, and backed by the evidence, in many cases, we end up with fewer eggs in that sort of luteal phase stem. Now, there are situations specifically in women with diminished ovarian reserve where we might suggest doing a duostem. But in general, my recommendation is always going to fall towards a back-to-back cycle as opposed to a duostem, because there's some evidence that shows that duostem can give you, even up to 25% fewer eggs. And obviously what we're looking for is more eggs. Journey to Baby W. Boy, I like that name. Here's a question, and I don't want to mispronounce your name because I already did once. Nick and Cram, I think, is what we're going to say. Your handle is there. What is an endometrial scratch, and when do we do it? This is not an endometrial scratch. All right, that's me looking like a monkey. Yeah. An endometrial scratch is basically an endometrial biopsy that's done in the luteal phase before doing a transfer. So remember that we talked about before that a luteal phase, so the first part of the cycle is the proliferative phase, and the second part of the cycle after ovulation, that's what we call the luteal phase. And why is it called the luteal phase? Because there is a corpus luteum. Corpus luteum. which means yellow body. And that's kind of what it looks like if you actually look at an ovary. The corpus luteum is what's left behind when your ovary releases an egg. And when your ovary releases that egg, those cells, that corpus luteum, starts to make your progesterone. And it's the progesterone that's needed to maintain your pregnancy. That's what a corpus luteum is for. It has a particular look on ultrasound, so usually we can look and tell what that is. But in the luteal phase, so after ovulation, the thinking used to be that if we did an endometrial biopsy, which is where we place a little straw on the inside, suck a little piece of tissue out, that it's going to create a little damage in the lining of the uterus that's going to result in an immune response that may improve the odds of pregnancy. So an endometrial scratch is an old-timey thing that used to be a matter of routine. The data now shows us that an endometrial scratch does not improve pregnancy outcomes. There still may be sometimes that we recommend it. When we don't have anything else to offer, we don't have any other good reason to figure why things aren't working. Sometimes we may say, well, you can try an endometrial scratch. And so again, a little endometrial biopsy, usually around day 21 or so of the cycle before you are going to do your embryo transfer. We get some valuable information from the tissue that comes out. What's the purpose of an endometrial biopsy? Well, it can show us, well, one, that the brain is talking to the uterus. What's the uterus hearing? And secondly, it shows us that there's not a chronic inflammation in the lining of the uterus. And so the tissue that comes from it is beneficial. Whether or not the physical act of doing it on the lining of the uterus is helpful to pregnancy, the data would suggest not. But there are still a lot of folks who will recommend it. It should no longer be a routine treatment or routine intervention in the IVF world. So hopefully that helps you there, my friend. Oh, let's see. We had some other questions over here. On average, this comes from my friend Haley. Hi, Haley. On average, how many embryos are genetically normal based on age? I am 28 with 6 day 5 embryos, all graded for AA. You know, I want to just mention something that we talk about with some frequency, and that is about embryo grading. And I will answer your question there, Haley. But to be clear, embryo grading was really developed so that it was a question of whether an embryologist can look under the microscope and describe different features of an embryo and attach some significance or a grading scale to those features, such that you could tell from looking at an embryo which one is chromosomally normal and which one is not. Well, as it turns out, it doesn't work that way. You can have a very highly graded, beautiful embryo, and that's what it is. It's a beauty contest. You can have this beauty contest winner and then do PGT testing on the embryo to see whether it's chromosomally normal and find that it has a large set of complex chromosomal abnormalities. Or you can have an quote unquote ugly embryo or a poorly graded embryo that is your only normal embryo in the bunch. So do we really rely on grading of embryos? And I would say the answer to that is no. Now, when we go to do an embryo transfer of untested embryos, we have to have some criteria by which we can select which is the one we're going to use. So we're just going to pick the prettiest one. They pick the highest graded ones, really for that reason. Generally speaking, I would say, in your 20s, you may expect, in your younger 20s, you may expect even, up to 80% of your eggs to have normal chromosomes. And that's why, for example, when we use an egg donor, we typically are seeking women who are in their young 20s because the odds of them having chromosomally normal eggs, the odds are going to be very high. As we mature, the eggs in the ovaries, the genetic material in those eggs becomes less stable, and so that's why it's just harder for us to get pregnant as we mature. So by 28, I would say really about 70% of your eggs should be considered or probably going to be normal, 60 to 70% eggs versus embryos. Once we get into our 30s, that number starts to go down. Certainly by 35, that number may be about 40%. And by the time we're 37, 38, that number may even be as low as 20%. And in our 40s, that number can be really sometimes even less than 5%. So that correlates with why it gets more difficult for us to have babies as we mature. But also why outcomes with IVF go down depending on our birth date. So, Haley, I think you're probably in pretty good situation there. Hi, Mariah E. Wagner. Nice to see you. And Cass N. Hi. Good to see you. Let's see what else we have here. Is there an email patients can reach you? Actually, you can always reach me through my Instagram, which is Randy Fink MD. Email is not always a good way to reach any of us because, at least for the providers at CNY, we are. Most of us do not spend a lot of time sitting at the desk in the ability to look at emails. Oftentimes you will email us and we may not get back to you in a timely fashion. And I will say, unfortunately for me, the same may be true for Instagram. I don't look at it every day. For a while, I was posting every day, and then I stopped doing it quite as much. I love it. I think it's fun, but as you all know, it's very easy to sit down and spend a lot of time looking at Instagram. And then, of course, we're looking at cat videos and golden doodle videos, dog videos, so I don't look at it all the time. But if you message me through Instagram, Randy Fink MD, it may take me a little bit, but I will get back to you on that. I've sent a lot of people our supplement list, and I do want to say just a few words about supplements because last week we said we're going to try to bring in a couple of different thoughts about this. There is a wonderful book here. And this is it. If you haven't seen it, and if it's backwards because of the cameras, then sorry about that. It starts with the egg. This is really the reference guide for what a handful of vitamins can do for you in human reproduction. It's written by a woman who I believe is a nutritional biochemist who herself had a diminished ovarian reserve in her young 30s. And so she poured through the world's literature to really find what the evidence shows, what the research shows can make a difference in terms of things like egg quality, whether you're trying to get pregnant at home or whether you're using an assisted reproductive technology like we do here, whether you are doing IVF, whether you have a normal or diminished ovarian reserve, things about sperm quality, things about recurrent pregnancy loss, things about polycystic ovarian syndrome and endometriosis, and even just generally things about embryo transfer. So Brandis and I have read this list and basically read this book and took out the list of the supplements and have them on a list for you. You can Instagram either one of us, and we're happy to send you that list through a company that's called FullScript, which makes it very easy to get them. And we can even put a little discount code on for you there too. I am a big believer that we can make a difference in egg quality, and egg quality is probably the number one thing that stands in the way of people getting pregnant because we're producing all of our eggs in the ovaries are not normal. So anything that we can do to try to make better eggs has the potential to be able to give us better IVF outcomes. And that's what she studied, and that's what our list shows. So please feel free to reach out to either of us through Instagram, and happy to share that with you. First thing I want to talk about, and I promise you we will get to some more questions here, but I do want to just talk a little bit about prenatal vitamins, which to some people is a dirty subject. Why is it a dirty subject? Well, because there's a lot of money to be made in nutraceuticals anyway, because really most of what these companies say, the claims that they can make about their vitamins are not regulated by the FDA. So they can really say whatever they want to, as long as they include that little statement at the bottom that says, this statement has not been evaluated by the FDA, and this supplement is not designed to treat any particular disease. Okay, well, what does that mean? Especially in pregnancy, and as it pertains to getting pregnant, people will do almost anything in order to get pregnant, and they're willing to make just about any type of sacrifice. And so when I practiced obstetrics, I would see on average about 10 different prenatal vitamin sales reps a week. There was a never-ending supply of prenatal vitamin sales reps coming into the office trying to get me to prescribe their vitamins. Now, many of their vitamins, and of course, we had a cabinet full of prenatal vitamins that we can often give a lot of samples for. But at the end of the day, what they wanted prescriptions. And many of these prenatals were not covered by insurance, and some of them might cost, $100 a month from the Walgreens to get this super duper prenatal vitamin that has, both kinds of fish oil. And I'm like, what do you mean both kinds? It's got, both from a goldfish and from a beta. Is that what you mean? Both kinds of fish oil. DHA and EPA is actually what they mean by that. But so fish oil omega-3 is definitely a good thing, but prenatals are, for the most part, prenatals. I personally do not believe that it makes sense to spend a great deal of money on a prenatal vitamin. Why is that? Because listen, if I could tell you, look, I've got, this vitamin here, and if you take this vitamin, I can tell you with a reasonable degree of medical certainty that your child is going to become a U.S. senator or possibly even president of the United States. But, the vitamin costs $75 a month. You might say, I wouldn't mind having offspring that's president of the United States, so I'm willing to scrounge up the $75 to buy that vitamin. However, I've yet to come across such a vitamin. So this one may have a stool softener, and this one may have an enteric coating, and this one has a different type of methylated folate, and this one has a little extra B6, so it's good for nausea. There may be some little nuances there. This one doesn't have as much iron. This one doesn't have as much vitamin A. There are some nuances. And so you find the one that you can take, that you tolerate, that's really the lowest cost. That, I believe, makes the most sense. And so really, is there anything better about a $5 prenatal that you get from Target? Actually, I don't know if you can get $5 vitamins from Target anymore. It's so expensive these days. Walgreens or wherever you fancy is a $80 vitamin necessarily any better than the $5 cheap one? Well, again, it may have a stool softener, it may be coated so you tolerate it a little better, you don't burp it up or something like that. But those are the nuances. It is not that one of them is better for your baby than the other. Or in the case of, and I think everybody who's trying to get pregnant should be on a prenatal because those micronutrients have been shown to make a difference in pregnancy outcomes. And of course, we should all be on folic acid, a minimum of 400 micrograms of folic acid for at least 3 months prior to conceiving, because that decreases the risk of certain types of birth defects. All right, fair enough. That's pretty easy stuff to accomplish pretty inexpensively. So, do you need to spend a lot of money on your prenatal? The answer is no, you really don't. What you need is something that you can tolerate and something that you can afford. Now, what about the fish oil? Or omega-3. The omega-3s can also come from things like krill. They can come from mashed up clam shells. There's calcium there as well. There are vegan sources of omega-3 also. Do those things make a difference? And the answer is yes. The evidence is pretty good that using fish oil makes a difference in outcomes. And so you will see on the list that comes from the book that omega-3s are on the list, and in fact, there's even an enhanced one that I have for specifically for sperm quality. What's the thing about fish oil? Well, if you've ever tried fish oil and you got one that wasn't what they call the odorless or the burpless one, you probably remember it, as do many of the people who are around you, because when you burp that up, it is extraordinarily unpleasant. It really doesn't. It doesn't taste good. So you want something that you don't have to burp up. So I do think in that regard, some of these fish oils or omega-3s are more purified than others, and so it gets some of that fishy flavor out. Some of them are compounded with things like natural lemon oil. So when you burp it, which just happens, it's natural, that you get a pleasant taste of lemon instead of sardine, and that's where many of them come from. So DHA and EPA are the two types of fish oil, and they are beneficial, especially if you can get them in combination. What is, do you think, the most important supplement, other than call it a prenatal or omega-3, that you can get as far as pregnancy goes? In my opinion, the answer to that is CoQ10 or coenzyme Q10, CoQ10, which is readily available all over the place, and particularly in the form that's called ubiquinol. You want to get it in the ubiquinol form because that is more easily absorbed by the body. And when you're using the ubiquinol form, you can use a little lower dose. It's 400 milligrams as opposed to 600 of non-ubiquinol CoQ10. What does CoQ10 do? CoQ10 is a cofactor that is involved in providing energy within the brain part of our cells, which is called the mitochondria. CoQ10 provides energy in the mitochondria. It is really critical for egg quality. It is critical for embryogenesis, making embryos, and even as it pertains to embryo transfer. So if you had to pick one thing other than a prenatal, which you can get cheap, that you should be on, I would tell you that one thing should be coenzyme Q10, CoQ10 or ubiquinol. Most people, I want to talk just briefly also about a couple of other things that are easy to take. Melatonin. Did you know melatonin, which you might use for sleep, is actually found in healthy eggs in the ovaries, and the healthier the eggs, the higher the concentration of melatonin. And so the recommendation, 3 milligrams of melatonin, is one of the things that's on the list from which there is great evidence to practice. It's also inexpensive. It's easy for you to get that. So if you're trying to get pregnant, I'd like to see you on a melatonin. 3 milligrams. You can get the gummy, you can get a capsule. Some people don't like melatonin. You take it at night because it does make you sleepy, or it probably will make you sleepy. I know some folks who it gives bad dreams to, in which case, if it's making you uncomfortable, don't take it. But that's an easy one to get a hold of. And vitamin D is the other thing. So we really want to see your vitamin D levels between about a 60 and an 80. And most people are in fact vitamin D deficient. So the one that I recommend is a liquid. It's a combination of vitamin D, D3 with K2. And again, happy to send you the link for this. Vitamin D3 with K2, when they put vitamin K with the vitamin D, what they found is, and it was a great study that was called the Rotterdam trial, they found that there was, in fact, probably the most exciting news in cardiology in the last 15 years. There was a 50% reduction in plaques in the coronary arteries and about a 50% reduction in cardiac death. That's big news, because what's the reason most of us are going to die? It is the heart. So vitamin D3 with K2, 5,000 units a day. The one that I use is one drop is 1,000 units. And so it's 5 little drops, ding, 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 of the D3 with K2, and to shoot for a level of 60 to 80. Our standard normal dose or a normal value for vitamin D is anything above a 30. But in the fertility world, and also certainly in the anti-aging world, 60 to 80 is what we're looking for. All right, I think I have said enough. So let's see what we can do to try to get to some more questions here. Siciliana Melissa says, having 7 euploid embryos, how does one decide which embryo to transfer first? What is considered the best grading? So the easiest way to do that is, Melissa, just ask our embryologist, which one should I transfer? So if you have euploid or tested embryos, you'll know, if you wanted to know the gender of those embryos. So that may be part of separating out, well, gosh, we really wanted to have a boy. Okay, so then you're going to take your male embryos. And what they will look at is which one kind of looks the best to them. And that is a question, it's a qualitative question of grading, but they can kind of look and say that, they're just going to pick what is otherwise the prettiest embryo to start with. Because once you have a euploid embryo, the grading really doesn't matter so much anymore. Because again, that whole point of grading was to see if you could tell which one was going to be euploid, and you can't. So that's how I would do it, Melissa. Just simply ask the embryologist for their advice. This is what they do all day long. And remember, it's their job to sit and look under microscopes at embryos. All right. Hopefully that helps you there. Oh, we've got all kinds of people. Hi, Creative Love 86 from Savannah, GA, which is my first out of town field trip I ever took, because I grew up outside of Atlanta, and we went, I think I was probably in the 3rd grade. We went to Savannah. Let's see. Hello from Atlanta and from Oklahoma. Boy, we got everybody in the CNY Nation here tonight. Thanks for being here. Don Soko says, good day to you and your great parents, and to Dr. Kiltz and his special lady if he's watching. I will make sure that he hears that. Thank you very much. And thanks for sending regard. Mom, did you hear that? Somebody over here on the CNY side said to tell you hello. Thank you, Don Soko. Very nice. What else we have here? Dr. Corley, I think we're talking about, this is from your SD bestie, Dr. Corley, who is one of our brilliant doctors in Syracuse, allowed me to record mine. It was super detailed and amazing. He is a great guy. If you've never met Dr. Corley, he is a bit of a character. He is one of my favorite people in Syracuse. If you're in Syracuse, ask for him. If you're doing a consult, an incredibly bright guy, and can't speak about him highly enough. SD Bestie, thanks for that. And I'll make sure that he knows that you said so. Let's see what else we've got here. Boy, we got a lot of people join, not so many questions. Do you guys prescribe progesterone for all IUIs, or does it depend on the patient? This comes from Nikki Jones Fit. Hi, Nikki. Well, I'll tell you. As a matter of course, we generally do supplement progesterone. again, what happens? Well, with an IUI, we're taking sperm and we are separating out the best and the strongest swimmers, and we are placing them inside the uterus at just the right time in order to try to maximize the options of sperm meeting egg. Well, what's the hormone that we need to maintain the pregnancy? It is progesterone, and the progesterone comes from the corpus luteum. Yeah, you got that. So progesterone comes from the corpus luteum. But if there's some deficit or deficiency in the corpus luteum and you're not making enough progesterone, that can have an adverse effect on pregnancy. So as a matter of course, certainly in the IVF world, where we're doing, let's say if we're going to do a medicated cycle and put an embryo back, we have to give you that progesterone because the body's not making it, right? With an IUI, you have released an egg that sperm's going to try to fertilize, but we want you to have a little more progesterone because remember, progesterone is the magic sauce. And so anything that we can do to kind of improve that and improve the odds of being able to maintain the pregnancy. Now, we generally do check levels, and there are some people who end up needing more progesterone than others, but in general, everyone should expect to get some progesterone after a treatment. And in the case of an IUI, it's usually a vaginal suppository. It's just some vaginal progesterone. We don't have to use the progesterone in oil or PIO shots. That's associated with a medicated cycle frozen embryo transfer. On the Facebook side here, Andrea asks, do you still get a corpus luteum when you do a retrieval and then a fresh transfer? Well, the answer is yeah, that's actually a good question, Andrea. So, you're making all those little follicles, which we're then going to suck the egg out of. And what's left behind does, in fact, become a corpus luteum, and you will make progesterone from that corpus luteum. However, we need to give you more. So that's why we still use the PIO shot and the vaginal suppository, because more is merrier. Good question, Andrea. Looks like Savannah Von DeFranco is asking, is elevated prolactin a major cause of infertility? So prolactin is a hormone that comes from the pituitary gland that stimulates lactation in the breast. Prolactin is something that generally we check as part of our preconception labs because an elevated prolactin level is a very common finding in fertility populations, folks presenting to a fertility clinic, for one of two reasons. One, you can develop a little growth in the pituitary gland. Sometimes that growth can be big, but usually it's what's called a microadenoma. It's a small growth in the pituitary gland. You can develop a macroadenoma, and that's a big growth. Or some people just have kind of an overgrowth of the gland itself and they produce too much prolactin. Sometimes medications can cause you to make too much prolactin. In fact, even if you stimulate the breasts enough, you can probably get your prolactin level to elevate. Well, prolactin can cross-react with some things. It can cross-react with the thyroid gland, and that can interfere with pregnancy. And prolactin also cross-reacts with your FSH hormone and your LH hormone, and these are the other hormones that come from the pituitary gland. So oftentimes people with an elevated prolactin will stop getting periods because there's an issue with the FSH and the LH, those other pituitary hormones. And so one of the things that is classic wisdom that you would check in a patient who presents to you not having periods is to want to check their prolactin level just to make sure that it's not standing in the way. So as that prolactin gets a little elevated, it can start to interfere with the normal functioning of the hormones. And so we like to correct that. There's a medication that we use that's called cabergoline that is typically taken twice a week. Cabergoline will do a couple of things. It will normalize your prolactin value, and if you have one of those little growths that we usually would diagnose by doing an MRI of that portion of the brain, it will shrink that microadenoma. It will make it smaller. So. The other reason that we want to treat that prolactin is because an elevated prolactin is going to increase the miscarriage rate. So it's a number that we check as a matter of course in preconception tests, and we want to see it normal. Looks like Ashley Deb is saying today is day 8 of STEMS for me. We go in tomorrow morning for a lab and ultrasound monitoring, and then from California to Colorado for a retrieval this week. Ashley, we will look forward to seeing you here. The ideal minimum stimulation time is about 9 days. So we like to see you stimming for 9 days. We all will generally find better egg quality if your stimulation lasts between 9 and 12 days. Ashley, we will look forward to having you in Colorado. Joanne Joe 101, what do you think about PGTA testing for a 33-year-old with unexplained infertility? Well, PGT is one of those things where people have in general, kind of a misunderstanding of what it does for them. Certainly for someone who has recurrent pregnancy loss, I would say 100% you want to do PGT testing because chromosomal issues are the most common reason that folks will lose pregnancy. So if we can separate out those that are chromosomally normal, those are our highest chance for pregnancy. That gives us our best odds for pregnancy. It's about a 60% chance of pregnancy with every euploid or chromosomally normal embryo. As a point of reference for unexplained infertility, we don't really know why people aren't getting pregnant. I would, and that makes up really honestly the vast majority of the population who are undergoing IVF to make those embryos. I would think about it this way, Joanne Joe. Yes, I do think it's valuable, and there are plenty of clinics around who will only transfer euploid embryos because they don't want to mess with their numbers. They only want to do the ones that have the greatest probability of achieving a pregnancy. The problem is that the testing is not perfect. It's a 60% chance of getting a baby, not 100. And why is that? People can still miscarry, unfortunately, and that really stinks when it happens, especially with a tested embryo. But think about it this way. If you have a large group of embryos, let's say that you have 10 embryos. Okay, well, that may be a lot of transfers that you have to do in order to come upon, let's just pick numbers here. Let's say that you're going to have 5 normal embryos. Depends on how old you are, of course. Let's say that you've got a 50% normal rate that you expect, and you've got 10 embryos. 5 of them are going to be normal. You may have to do 5 transfers before you get to the first one that's normal. And that is a big drain on you financially and certainly emotionally. The emotional cost of doing all those transfers, the emotional cost is high, as probably any of you can tell me. So what does PGT do for us? Well, the first thing it does is that it's going to let both nature and science help us to pick the embryo that has the greatest probability of getting us pregnant. So first, nature has to do its thing. These embryos have to grow to the blastocyst stage, and all your embryos aren't going to grow, right? Some of them will stop growing, they will die off. And these are likely embryos that would not have gotten you pregnant anyway. Likely, not guaranteed, but likely. So nature's doing its first sorting process. So of those 10 embryos, let's say that we lose 3 of them and now we have 7. Okay, well, of those 7, now we do PGT testing and we can see which ones are chromosomally normal. And let's say that of those 7, we're going to end up with, 3 of them that are chromosomally normal. I know that's a little different than the numbers I just used before, but let's say 3 are normal and 4 are not. Well, we know that we're going to start with those euploid or chromosomally normal embryos because they have the highest probability of getting us pregnant. We just saved ourselves a lot of effort and a lot of emotional capital, notwithstanding the financial aspect of that as well, to find out which ones were normal. So in that regard, yes, I do think it is useful. Now, let's say instead you have 2 embryos. Well, is it worth doing PGT testing on 2 embryos? And I would say the answer to that is probably not, because you could put both those embryos back in. You could transfer them both. They're either going to stick because they're normal or they're not. And your body is going to give you that same information without having to pay the laboratory and pay for the biopsy to get the PGT done. So if you're limited in the number of embryos, first of all, don't risk growing them to the blastocyst stage, because you may end up with nothing. Whereas that day 3 embryo, if we put it back inside of you, it may have a chance to grow inside of you, whereas it may not have grown in the lab because of, again, like I like to say, the magic sauce. You have the magic sauce. The lab is a knockoff. We're just trying to be like the magic sauce, but your uterus is far better than any lab that we have. So hopefully I answered that question. But PGT is a confusing subject to people, because people say, well, I have to do the PGT testing because I want to have a normal baby. And I say, oh, you're one of those people that wants a normal baby. Well, you get in that line over there, because this line over here is for those of us who want an abnormal baby. Nobody wants an abnormal baby, and that's not what PGT is for. It is not about the health of your pregnancy or the health of your baby or the likelihood of a delivery. It's about helping to separate out which embryos have the greatest probability of getting us pregnant. We're going to be wrapping it up here. Boy, I did a lot of talking today and not a lot of question answering, so my apologies. Is testing a day 3 embryo on day 13 too early? That's when I'm supposed to do an HCG test. Oh, I see. Doing a pregnancy test. No, that's the right timing. So after you do your transfer, we will give you the dates of when you do your midway labs, which is when we want to really look at your progesterone, and when we want to do your beta. A reminder, if you are interested in reciprocal IVF, in about 30 minutes from now, I will be hosting a Teams meeting where we go through that process of reciprocal IVF and answer questions. It'll be a smaller gathering than what we have here, but you are welcome to join us, and the invitation is on the CNY Instagram page in the bio portion. I think it's probably listed on the CNY Facebook page as well. Let's see if we can get a couple other questions answered in the last few minutes. Alicia is saying, oh, by the way, hi, Annie. Alicia is saying, I will be there to do a transfer with you in 2 weeks. Woohoo! And when should I get my IVIG administered? Usually in the day or two before the transfer is when you do IVIG. Let's see. Oh, Cass, thank you, Cass. It's pronounced newer. I feel better now. And hi to Alexis in Miami. It's great to see you. Thanks for being. She is, of course, one of our perfect nurse practitioners at the Miami Center of Excellence and CNY Fertility at the Miami Center, one of our premier monitoring sites, and a place for gynecology, sexual medicine, and bioidentical hormone therapy. Does being menopausal make endometriosis better? In most cases, the answer is yes. Endometriosis is fed from hormones. And in the menopause, what happens to your estrogen level? It goes away. The estrogen is made by the eggs and the ovaries. And when we run out of those eggs, that is really what sort of defines menopause. And in most cases, menopause is curative to endometriosis. Not always, because there certainly are some people who continue to have endometriosis related problems after menopause, but it is certainly more of a common finding in those of us of reproductive age. Gosh, looks like that's going to be all the time. Thank you, Erica. You say nice things to me. I appreciate that. And hi to Eileen there as well. Everybody, thanks so much for being a part of my evening and for letting me be a part of yours. As always, every Tuesday evening, 4 o'clock in the Mountain Time is time for Fertility with Fink and Friends. Here on Instagram, on Facebook, on LinkedIn. Remember, infertility is not your book. It is not the story of your life. It is merely one chapter. And what we do here is help you to rewrite that chapter. So God bless all of you. Thanks for being here, and I'll look forward to seeing you next week. Till then, good night. Toodaloo.